Hello people, welcome to this video on ophthalmology top priority questions part 2. In part 1, what have we looked at? Errors of refraction, accommodation, conjunctiva, cornea, sclera, uvea, lens, glaucoma, all this we have seen. Now in part 2, let us look at retina, strabismus, squint, ocular motility, eyelid, lacrimal apparatus, ocular pharmacology, systemic ophthalmology and community ophthalmology. So in retina, the most important thing they're asking is retinal detachment. So retinal detachment means between the layers of the retina you have separation, so that is retinal detachment. Then in that you have three types. You have rhegmatogenous, exudative, tractional. So rhegmatogenous, there should be a break through which the vitreous will enter and cause the detachment. So basically here you need a break, remember. And why in retinal degeneration there can be breaks, holes, etc. See lattice degeneration, snail track degeneration, so many types of degenerations because of which there's a hole, break, whatever, through which the vitreous can enter. You have the Linkoff's rule to locate the break. Then this will then lead to detachment. But to locate the break, they have some Linkoff's rule. Okay, then so that this break doesn't lead to a retinal detachment, they will do laser photocoagulation or cryotherapy so that they can seal this break, isn't it? And then you have prodromal symptoms. They will have floaters and photopsia, that is flashes of light. They can have sudden painless loss of vision, appearance of a dark cloud, relative loss of the field of vision. They can have Marcus-Gunn pupils, scotoma. They can have gray reflex, gray. Everything will be gray because of this detachment. The ERG can be subnormal or absent. Okay, then this is horseshoe tear. This is a round tear, and this is a anterior dialysis. This is a round hole. They are saying this is a hole. This is a tear. This is a dialysis. Okay, you can see tobacco dust in anterior vitreous. This is Schaffer's sign. This is pathognomic of retinal tear. Tobacco dust, where will you see, guys? Rhegmatogenous retinal, the retinal tear, you can remember. Complications, if you don't treat, then what will happen? It can, interestingly, a retinal detachment can lead to cataract. How strange, right? To complicated cataract to uveitis, then how inflammation started coming, okay? Proliferative vitreoretinopathy, the first thing seems to be vitreoretinopathy. Then thesis bulbi shrunken non-functional eye, so it can become a non-functional eye. How sad, okay. Then principle, how will you treat? You seal the break. We already told you that laser photocoagulation, cryotherapy, etc. Reduce the traction, flatten the retina by draining the subretinal fluid. So whatever fluid vitreous has gone and accumulated there as subretinal fluid, you will drain it and you will put tamponade. There are so many ways of doing this, guys. Sealing the retinal break, drain the subretinal fluid, maintain the chorioretinal opposition by scleral buckling, pneumatic retinopexy, pars plana vitrectomy, all this, guys. You have to remember these names, okay? So once you remove the fluid, what are you doing? You'll maintain the opposition by scleral buckling, pneumatic retinopexy, and some internal tamponade. They're talking about some sulfur hexafluoride perfluoropropane. Wow. So these are some images. So this surgery will help, okay? Next, what is the next topic? In very important, hypertensive retinopathy. Let's look at hypertensive retinopathy. Now, hypertensive retinopathy, because of high blood pressure, systemic hypertension, what and all are the blood vessels affected? Normal fundus. What will you see in hypertensive retinopathy? You have some grade 1, grade 2, grade 3, grade 4 according to Keith Wagner classification. So you have hypertension can cause retinopathy, acute choroidopathy, neuropathy. All this it can lead to, looks like. So don't take tension in life. Hypertensive retinopathy they're talking about here, there will be vasospasm that leads to hypertension, arteriosclerotic changes, increased vascular permeability, raised intraocular pressure. So there are two things here, benign or chronic hypertensive retinopathy, malignant hypertensive retinopathy. All this we have looked at in our videos, isn't it? Detailed videos. So here they're showing what copper wiring, silver wiring, AV nicking. So what are they talking about here? Salu sign, bonnet sign, gun sign, copper wiring, silver wiring. So here they are showing you bonnet sign, here they are showing gun sign. So all these are types of arteriovenous nicking, Salu sign, bonnet sign, gun sign. Then in fundus, what and all you will see? Hard exudates, flame-shaped hemorrhages, cotton wool spots. You should remember these, okay? What and all will you say? Hard exudates, that is lipid deposits. Then you have cotton wool spots, infarcts of the nerve fibers, and flame-shaped hemorrhages. Guys, you also have something called as malignant hypertensive retinopathy. That, well, what are they talking about? Microaneurysm, Elschnig spots, Segrist streaks, disc edema. So they have this staging, modified Shee's classification. So stage 4 retinal edema, hard exudates, optic disc edema. Management of hypertensive retinopathy. Proliferative diabetic retinopathy, let's look at. Proliferative diabetic retinopathy. So diabetic retinopathy is a leading cause of blindness. They are saying here there are so many risk factors. So what will happen? There is hyperglycemia, microangiopathy, oxidative stress, hematological and biochemical changes because of all the hyperglycemia. So that can be microaneurysms, ischemia, VEGF. That will then lead to neovascularization. So you have diabetic retinopathy. Guys, how's it going? It's just going above the head. Is it fine? Okay. Diabetic retinopathy types, you have non-proliferative, and again that you have mild, moderate, severe, very severe, proliferative, then diabetic maculopathy, advanced diabetic eye disease. In the exam, they seem to be focused more on proliferative diabetic retinopathy. This comes very later in life only, but still for young people who are diabetics, they can get it sooner, right? So that is a problem. So proliferative diabetic retinopathy after about 20 years of onset of the disease. So occlusion, hypoxia, VEGF, neovascularization. So this is the hallmark of proliferative diabetic retinopathy, neovascularization. There will be capillaries, right? New. You have the NVD and NVE. NVD means neovascularization at the optic disc. NVE is neovascularization elsewhere. And what will happen? There can be vitreous hemorrhage, loss of vision. Types of proliferative diabetic retinopathy. So same NVD and same thing. You have without high risk characteristics and with high risk characteristics. High risk characteristics means what? Vitreous hemorrhage, pre-retinal hemorrhage, all these seems to be some high risk. Okay. We have looked at all this in the detailed video. Look at that. So these are some images. Then diabetic maculopathy, diabetic macular edema, effect on vision it will have. Advanced diabetic eye disease, they're saying persistent vitreous hemorrhage, tractional retinal detachment. We already told you in retinal detachment types, you have tractional. Tractional will be because of diabetic eye disease, neovascular glaucoma, because of all the new vessels, looks like there is glaucoma. So these are the three you have written advanced diabetic eye disease. Okay. So management, treatment, anti-VEGF drugs, Bevacizumab, Ranibizumab. Okay. YAG laser, photocoagulation. All these photos, do you remember how you are doing? This is focal, this is grid, and this is pan-retinal photocoagulation. Surgical, you have pars plana vitrectomy, endophotocoagulation, etc. Next, let's move to retinoblastoma, guys. So retinoblastoma, what did you see? It's malignant tumor, 13q, Knudsen height, 2-hit hypothesis. Then people will have osteogenic sarcoma also. They can have pineoblastoma also. Human karyotyping, we saw which one? 13th chromosome it will have. Then it has two presentations, quiescent presentation, painful presentation. Quiescent presentation, you have leukocoria, white reflex. They don't have pain, and these people will have pain. These people can have poor vision, strabismus. It is gross in pathology. If you see, it is creamy colored. There is endophytic, exophytic, right? And this is endophytic, this is exophytic. You can see the images, calcification and all. Then microscopically, you will see Flexner, Winter-Steiner rosettes, Homer Wright rosettes, necrosis, calcification, right? Then you should be able to differentiate from other causes of leukocoria. Diagnosis, how will you do, guys? You will do MRI, you can say. You'll check the LDH level. You'll examine the fundus, the eye. Classification of retinoblastoma, you have A, B, C, D, E. E is very high risk, massive retinoblastoma. A is very low risk. It is less than 3 mm and it is confined to the retina. Okay, and it is far from the fovea and of the optic disc. So basically this arises from retinal neurons, blast cells, the blast cells. So it's retinoblastoma, primitive cells. Treatment, how do you do? Remember the CVC regimen, chemo reduction by using carboplatin, vincristine, etoposide. And remember focal therapy, you have you will break down the tumor using cryotherapy, laser photocoagulation, thermotherapy. Then enucleation, group E, you can, for group E, that is very severe or something, right? Very severe, you will do enucleation. Wait, let's check that. See, very high risk, very high risk. That group E you will do, they will do enucleation. Okay. So then enucleation. Then they are also talking about palliative therapy when you have to just the prognosis of life is dismal. They're talking about again CVE regimen, same thing. Okay, radiotherapy, etc. They want to do orbital exenteration. They want to remove the content of the orbit. Okay. So prognosis, if it is early detected, early treated, then it is better. Shall we continue, people? We are looking at now. Let us move to this optic atrophy under neuroophthalmology. Okay. So what have we seen in optic atrophy? These people will have Marcus gun pupil. Okay, very good. What is optic nerve atrophy? The second cranial nerve, that is the optic nerve, will get degenerated. So this can be a optic nerve disease. A lot of things can lead to optic atrophy, guys. So what is happening from the retinal cell ganglions to the lateral geniculate body, damage to the axons will lead to optic atrophy. Okay. So here optic atrophy, they have shown primary, consecutive, post-neuritic or secondary and ischemic. So what should you know here? There are so many types of optic atrophy. You have primary simple optic atrophy, post-neuritic optic atrophy or secondary. Then you have consecutive optic atrophy because of retina choroid, that will lead to consecutive optic atrophy, glaucomatous optic atrophy and vascular or ischemic optic atrophy. So there are 5 optic atrophies that you will mention. So you should know the colors. Primary will be chalky white, the appearance of what? Secondary or post-neuritic dirty grey. Consecutive is waxy pallor. You will see in anyways in retinitis pigmentosa, you will see waxy described. Same thing, waxy pallor. Consecutive. So you can remember this, right? Optic atrophy, the primary one is because of the lesions which are proximal to the optic disc, right? It's more because of the optic disc and its surroundings. So you have some tumor or some trauma, toxic amblyopia, multiple sclerosis. Basically, there is without antecedent papilloedema. So something around optic disc only you remember. So what did you see? They said it will be white. Can you see white? Yes. Then you saw that, yes, the disc is chalky white. Post-neuritic optic atrophy, this is secondary optic atrophy because of long-standing papilloedema and papillitis. So here there is papilloedema, papillitis, that is secondary, right? So here what did they say? The color is grey, right? Grey, they said dirty white in color. And here there will be, due to gliosis, the edges are blurred, the physiological cup is obliterated, lamina cribrosa is not visible, retinal vessels are attenuated, perivascular sheathing is often present. Coming to consecutive optic atrophy, guys, here what did they tell you? It is because of choroid retina, something a little away from the optic disc kind of a thing. So here, what will you blame? Chorioretinitis, retinitis pigmentosa, central retinal artery occlusion. All this you can blame. Pathological myopia also they are blaming. Okay. So basically, destruction of ganglion cells secondary to the degenerative or inflammatory lesions of the choroid or retina. Blame the choroid or retina here. Here the disc will be yellow waxy. Then you have glaucomatous, vascular or ischemic due to severe anemia. Then you have ascending or autograde optic atrophy. Then you have retrograde optic atrophy also, descending. So there is the degeneration and gliosis, primary optic atrophy. Degeneration with excessive gliosis in post-neuritic consecutive. Okay, here in primary it is orderly. Okay, then you have negligible gliosis in ischemic and glaucomatous. Look at these people, they can either not see in the center or they can see only in the center. Only in the center, where did you see? In glaucoma, right? In the center they cannot see. This you have seen in optic neuritis. So Marcus Gun pupil, remember Marcus Gun pupil can be there where and all? In retinal, rhegmatogenous retinal detachment you have seen, in optic atrophy you have seen, right? So how will the disc be? We already saw white in this primary, right? Basically white in primary, dirty grey in secondary and waxy pallor in consecutive. Remember in secondary the margins are ill-defined. Where are the margins ill-defined? In secondary the margins are ill-defined and obscured lamina cribrosa in secondary. Next question, enucleation. So enucleation means what? You will remove along with the sclera, you will remove the eyeball. So where and all will you do this? In retinoblastoma and malignant melanoma. Those two are very important. Those two you have to remember. Basically cancerous they are removing, remember, the entire eyeball. Okay. These are some other small relative indications. For eye donation they will do enucleation. Remember, eye donation, tumor, eye donation, cancer and tumor. So cancer and eye donation. Okay. Sympathetic ophthalmitis when it's not working and they want to really save the other eye. They want to enucleate the blind eye. So look at this. They are doing separation the conjunctiva tenon capsule, separation of the extraocular muscles, cutting the optic nerve. See, remember in retinoblastoma, they'll do enucleation with a part of the optic nerve, with maximum part of the optic nerve. That's what they say, right? You should remember this. So remove the eyeball, put an orbital implant like a PMMA med for some kind of orbital implant, and then they'll close the conjunctiva tenon capsule. Prosthetic eye they will put. See here? They've shown prosthetic eye. So this is that PMMA, is it? Something like this, but there are a lot of things and PMMA is one of them, looks like. So they have some enucleation spoon, enucleation scissors. See, you know the difference, evisceration, enucleation, enteration. Enucleation is one that we talk about by removing the eyeball, the sclera also, and part of the optic nerve in retinoblastoma, maximum part of the optic nerve. So what were the indications we saw? Retinoblastoma, malignant melanoma for eye donation, and then sympathetic ophthalmitis, etc. Next one is this one, Marcus Gunn pupil. Marcus Gunn pupil, do you remember where you saw it? We have seen it in this optic atrophy, and we have also seen in retinal detachment, okay? Yeah, the next one is optic neuritis, guys. Optic neuritis, what have you seen? It includes inflammatory and demyelinating disorders of the optic nerve, okay? So most commonly it is because of multiple sclerosis, mumps, measles, chickenpox, sinus-related, cat scratch fever, syphilis, so many other autoimmune diseases. So what are they saying here? Demyelinating diseases like multiple sclerosis, Devick's disease, diffuse sclerosis. All this you should know. Clinical profile, guys, how will it be? The papillitis, optic disc is inflammatory. Papillitis, neuroretinitis, retrobulbar neuritis. Then what is this? Fundus photograph showing papillitis. Clinical features, visual loss. There will be pain, glowing sensation. There is some symptom here. Moving away from heat. Object may be impaired. Moving object may be impaired. Pulfrix phenomena. Uthoff's symptom. There are some very specific words. Pain here. Dull, mild dull eye ache. So fundus photograph showing papillitis. Inflammation of the optic disc. Signs, what and all you will see. Visual acuity is markedly reduced. Color vision is severely impaired. Red looks lighter. Marcus Gunn pupil. So Marcus Gunn pupil you saw where and all? Optic neuritis, optic atrophy, retinal detachment, severe retinal detachment, etc. Guys, are you paying attention? Very important, you should write this. Discus edematous, blurring of margins. So there can be central scotoma, centrocecal scotoma, reduced visual evoked response, reduced amplitude and delay in transmission time. Then what is the treatment for optic neuritis? You have to treat the cause. Then what is this? Steroids they are giving intravenous. Next, let's look at papilledema. Disc edema, guys. Papilledema with raised intracranial pressure. Okay, always bilateral, although it may be asymmetrical. Always bilateral, although it may be asymmetrical. Means what? not be equal on both sides or something. So causes of disc edema they have told here. AION, anterior ischemic optic neuritis, right? Etiopathogenesis, space occupying lesions, intracranial space occupying lesions like brain tumors, right? Meningitis, subarachnoid hemorrhage, obstruction of CSF absorption. So basically intracranial pressure is more, that's what you have to remember. Idiopathic intracranial hypertension, that means they don't know why. Pseudotumors cerebri, something like that. So these people, the patient will have headache, projectile vomiting, transient blackout of vision, loss of vision. Guys, remember in the early stage there will be no symptoms, visual acuity will be normal, then pupillary reactions are normal, etc. But you can see obscuration of the disc margins, absence of spontaneous venous pulsation at the disc. Looks like this is a very important thing, looks like absence of venous pulsation. Transient visual obscurations, what are we looking at, guys? Papilledema. So transient loss of vision, what else you saw, guys? There is no pulsation of the venous something. Wait, let's look at that. What was it? Absence of spontaneous venous pulsation at the disc. So disc edema, veins become tortuous, engorged, patons, lines. What are these? Then enlargement of blind spot. So guys, how will you treat this? You will have to do CT scan or preferably MRI, it says, and you will have to treat the cause. You have to treat the cause. Guys, let us move on to the next topic here, ocular motility, extraocular muscles. So which are the extraocular muscles? You have voluntary and involuntary. Voluntary, they are giving recti, superior rectus, inferior rectus, 4 rectus, 2 oblique, superior oblique, inferior oblique, levator palpebrae, superior. So these are totally 7 here. And involuntary are also there, because they are considering these are also as extraocular muscles, like superior tarsal, that is Muller's muscle, inferior tarsal and orbitalis. Here the chances of forgetting these muscles are more, which these you will write. So rectus and oblique you will write. Levator palpebrae superioris you should write. Superior tarsal, inferior tarsal, orbitalis you should remember. If they ask muscle names, don't forget you write nerve supply also, LR6, SO4, rest 3. Action of individual muscles, lateral rectus, medial rectus, no confusion. This one does abduction, this one does adduction, this two no confusion. So it's shown here. Lateral rectus, medial rectus, no confusion. Medial will pull medially, lateral will pull laterally. Then here you have superior rectus, inferior rectus. Again, superior, inferior, same position they have taken. The only different thing here is superior oblique is down here and inferior oblique is up here. This one is different. Superior is down here. So this is going to intort, right? Like this, intort, superior oblique. So the recti muscles, from where are they coming? So if this is the eyeball, right? You have the recti muscle coming from the common tendinous ring, okay? And these are the recti origin inserted into the sclera, annulus of Zinn. Superior oblique, from where it comes, from body of sphenoid insert into sclera. There is a trochlear notch, some special pulley system and all. It has the superior oblique. Inferior, it inserts into sclera. Everything is inserting into sclera. From where is it arising? You can just check it. From floor of orbit, you can see. Here you can see superior oblique, its pulley system, and inferior oblique is here. Don't forget levator palpebrae superioris for the eyelid, right? So if this is the eyeball, here you have the eyelid. So you should be having the levator palpebrae superioris. So its action written here, elevation of upper eyelid. So very important. It will elevate the upper eyelid, right? And it has some 3 lamellae, upper, intermediate, lower lamellae. So lower inserted onto the superior fornix or conjunctiva, upper skin of upper eyelid, superior tarsus plate. See, levator palpebrae superioris here, they have shown it. Levator palpebrae superioris here. From where is it coming? From under surface of the lesser wing of sphenoid at the apex of orbit above the common tendinous ring by a narrow tendon. Origin. They have asked about amblyopia, very important. So this is reversible loss of vision in one or both eyes. No cause they have. They have no cause found by physical examination. So there is absence of any organic disease. There's no disease as such. So basically what is happening? This is reversible only up till some years, okay? 10 years or what? 10 years of age kind of a thing, right? So you have so many types of amblyopia, strabismic amblyopia, stimulus deprivation amblyopia because of cataract, ptosis, congenital opacity, anisometric amblyopia you have, isometric amblyopia, meridional amblyopia. So their visual acuity will be reduced. What else? So they want to, what is the treatment? Occlusion of the good eye. They want to occlude the good eye. So this is the good eye, this is the not so good eye. So they will occlude the, which eye? The good eye for few hours in the day so that the lazy eye starts developing vision. So here you can see occlusion therapy, penalization, blurring of the vision of normal eyes. So they are trying to blur the normal eye so that they use the child is forced to use the lazy eye and develop it. Okay. Pleoptic exercises, so some exercises, pharmacologic manipulation, perceptual learning. Then paralytic squint, guys, let us look at this. As such, squint, you have heterotropia and heterophoria. Under heterotropia, you have concomitant and incomitant. Under incomitant, you have paralytic and restrictive. So this one, paralytic is here. Paralytic is here, guys. This one. So these people will have diplopia and a lot of, what is this? How do you describe this image? Disorientation, etc. Paralytic, okay? Guys, let's move on to eyelid. So in eyelid, what and all are important? Chalazion, hordeolum, externum, symblepharon, lagophthalmos, ptosis, blepharitis, Horner syndrome, all are important. Let's start with chalazion. So chalazion affects what? Meibomian gland. Meibomian gland is a sebaceous gland, isn't it? So you have, it is also called as meibomian cyst, this chalazion. It's common, non-infective, it's painless, and it is lipogranulomatous, right? If it gets infected, it can turn into an internal hordeolum. So remember, it is lipogranulomatous. It's not infective. It's not an infection. These people will have only cosmetic problem, and they can have some astigmatism because of pressure on the cornea. The problem is this can become a malignant change. So how will you treat it? Conservatively, self-resolution, hot fomentation, intralesional injection of triamcinolone, and then they'll do incision and curettage with all these special equipment like, what is this? Scoop, chalazion scoop. This one is chalazion scoop. What is this one? This is a chalazion holding clamp or something. Wait, I'll tell you. Diathermy is also type of treatment. Yes, guys, it's a chalazion clamp. Then they're asking external hordeolum. External hordeolum, let's look at. External hordeolum means somewhere here you will have a problem. So gland of Zeiss. Gland of Zeiss is also sebaceous gland. So this will become external hordeolum. Okay. This is infective. There will be organism. Pain also. What do you say? Chalazion was painless. Next, symblepharon. Okay, guys, symblepharon. Are we moving to symblepharon? Yeah, symblepharon. So basically here what is happening, the lids are becoming adherent with the eyeball. So basically the palpebral and bulbar conjunctiva are sticking to each other. This usually happens because of chemical thermal burns, membranous conjunctivitis, injuries, conjunctival ulcerations, ocular pemphigus, and Stevens-Johnson syndrome. So these people's ocular movements will become restricted. They can have diplopia, lagophthalmos. So this is anterior symblepharon, this is posterior symblepharon, and this is total symblepharon. So basically prophylaxis, what they are saying in the raw stage, in the early stages, you can just take a glass rod and try to remove this adhesion. Okay. Soft contact lenses so that they can prevent. In case it has become big and strong, then they will do symblepharectomy. Lagophthalmos. What is there in lagophthalmos? So basically eyelids are open. So anomalies in the position of the eyelid. Inability to close the eyelid voluntarily. So even if you want, you cannot close the eyelid. So it can happen in cases of symblepharon. Severe ectropion. The eyelid is rolled, turned outward. Marked proptosis. So the eye is popping out. How will you close the eyelid then? So basically you should remember paralysis of what? Orbicularis oculi muscle, because this is the one that tries to close the eyelid, right? Orbicularis oculi, remember, facial nerve palsy, cranial nerve 7. So all this can happen when it's the cicatricial contraction of the lids, eyelid scarring, myxedema, hypothyroidism. So many reasons are there. Comatose patients. So these people cannot close the eyelid, means what? It's so exposed. So they'll have exposure, keratitis, corneal xerosis, conjunctival xerosis, everything became dry eye. So basically what will you do? You will try to give them artificial eye drops, bandage contact lenses, tarso refi. Okay, then treat the cause. Next question, important ptosis. Where is ptosis? Here it is. So ptosis, drooping of what? The upper eyelid, abnormal drooping. Normally it covers 2 mm of the cornea. If it covers more than that, it will become ptosis. So you can have congenital ptosis, acquired ptosis like neurogenic, acquired myogenic, aponeurotic, mechanical ptosis. Congenital, basically, there is no proper development of the levator palpebrae superioris, etc. Congenital ptosis associated features, they have this blepharophimosis, simple congenital ptosis associated with weakness of superior rectus muscle. This one is some jaw winking phenomena, right? Marcus Gunn jaw winking phenomena. All this we have seen in detailed video. Acquired ptosis can be neurogenic, myogenic, aponeurotic, mechanical. So neurogenic, where will you see? Because of the nerve, third nerve palsy, Horner syndrome, multiple sclerosis, you can remember neurogenic because of the nerve. Myogenic because of the muscle. So here what will you blame? Myasthenia gravis. Just blame myasthenia gravis all the time. Then acquired ptosis. Again, third one, you have aponeurotic ptosis. So aponeurotic. This is some extra fold of the eyelid skin, right? What is that called as? Chalasis. Chalasis. Isn't it? This one? And then lastly, what are they saying? Mechanical, because of some chalazion or something. It's so heavy and it is falling down the eyelid. Okay. So you can check why the person has ptosis. You will evaluate, measure the amount of ptosis. Then you will do assessment of the levator function. Then what else? Tensilon test, edrophonium for myasthenia gravis. Guys, focus. What are we looking at? Ptosis. Very good. Then where are we? Here. Phenylephrine test for Horner syndrome, is it? Then this is the treatment for ptosis. Fasanella servat operation, levator resection, frontalis suspension. So we have looked at all this in the detailed video. This is what? Fasanella servat, tarsoconjunctivomulerectomy, levator resection, then frontalis sling. All this we have seen, right? Treatment of acquired ptosis, they're telling about same thing. Same way only you can treat. And treat the cause mainly, myasthenia gravis, etc. You can treat with, what would you give in myasthenia gravis? Neostigmine and all those. Now let's go to blepharitis, guys. Blepharitis is inflammation of eyelid. So what and all will you see here? Bacterial, say bacterial. Bacterial blepharitis. Then say seborrhoic. Yeah. Can you say posterior? Yeah, posterior blepharitis. And parasitic blepharitis. Say parasitic. Yeah, you have these four that you have to remember. Bacterial, seborrhoic, posterior and parasitic. So these are the four you have to remember. Bacterial, seborrhoic, posterior or meibomitis and parasitic. Okay guys. So each of these we have made separate video. Bacterial, ulcerative you can say. Yellow crust, staphylococcus. Remember staphylococcus you blame even for styes, right? Even for styes you will blame them. People who have dandruff and all, right? They can have the seborrhoic blepharitis. So Corvinibacterium acne. This is neutral lipids. Posterior blepharitis, meibomitis. This is in people who have acne, rosacea, seborrhoic dermatitis. These people will have this meibomitis. Okay. Parasitic blepharitis, lash infestation. You have to write these words: pediculosis, thyrus pubis, crab louse. Horner syndrome, guys, what should you know in Horner syndrome? So it is an oculosympathetic paresis. What and all will be there? Mild ptosis, meiosis, and reduced ipsilateral sweating anhidrosis. We have seen this in the detailed video. Pancoast lesion, then what are the three things that these people will have? In congenital Horners, they can have heterochromia. Look at this, left Horners they are saying. So what is happening in dark, light, hardly any difference. And in cocaine, there is constriction in cocaine. So basically remember, it fails to dilate. Cocaine fails to dilate in Horner syndrome. So they don't use cocaine. Now they have apraclonidine test. This one dilates the Horner pupil. Okay. Cocaine fails to dilate. And apraclonidine dilates the Horner pupil. Actually here what is happening? If it fails to dilate, that means it is already in constricted. Yes, it is ptosis meiosis, right? Yeah. Guys, we are moving to lacrimal apparatus. In this, what and all are important? Lacrimal apparatus anatomy is important. Tear film layers, acute dacryocystitis, chronic dacryocystitis, and dry eye. These are important. So look at this. So first, let us start off with the lacrimal apparatus. You have the main glands, accessory glands like gland of Cross, Wolf, Ring, lacrimal passages. You should know puncta canaliculi, common canaliculi will be there, right? Am I right? Lacrimal sac, nasolacrimal duct that opens into what? Inferior meatus. Okay, so tear film layers, they have asked tear film layers. You can see in this. You have a outermost, what will you have? Oily layer. And then this will be oil will be coming from where? The meibomian Z small glands, is it? So meibomian Z's glands you can remember. Then these will prevent overflow, they will prevent evaporation, they will lubricate the eyelid also. Then behind the oily layer you have watery layer. Watery layer is aqueous layer. It is coming from where? The lacrimal duct. This is the main thing coming from the lacrimal duct, right? Watery layer. So this will have water, sodium chloride, sugar, etc. And then behind all this you have the mucus layer. Mucus layer will be from where? From the goblet cells of conjunctiva, glands of Mans, etc. These convert the hydrophobic corneal surface into hydrophilic. So if this is the eye, and here you have the cornea, what are the layers? Mucus, aqueous, oily, clear film. What are the causes of dry eye? They have asked. Look at this. Dry eye, vitamin A deficiency, injury, chemical injury, trachoma. So mucin layer will get affected. Mucin layer is coming from where? From the goblet cells of the conjunctiva. Now, if there is some problem with the tear, that's the aqueous layer, then what and all will be the cause? Age. This is because of the lacrimal gland, right? Age, Sjogren's is it? Disease, syndrome, dry eye, dry mouth, rheumatoid arthritis is it? Contact lens, if you prolong use, then you will have this problem. Post-LASIK they can have because of nerves cut, it seems. Then drug-induced can be there because of anticholinergics, antihistamines, depressants, etc. Okay. Then lipid layer, they didn't mention as such any problem here. Okay. Dry eye, so you should remember vitamin A deficiency, age, Sjogren's, contact lens, post-LASIK, drug-induced, chemical injury, trachoma, etc., etc. Then acute dacryocystitis is acute suppurative inflammation of the lacrimal sac. So stages of cellulitis will be there, stages of lacrimal abscess, stages of fistula formation. Here you can see a fistula, isn't it? Looks like a fistula. This is what? Stage of the abscess. Okay. Then complication, acute conjunctivitis. Okay, these are the complications of acute dacryocystitis. Then what else is important? Chronic dacryocystitis, inflammation of the lacrimal sac, more common than acute. This is actually more common than acute. Mild grade inflammation, that is why chronically they are sustaining it. What are the causes? Staph, strep, pneumococcus, pseudomonas, TB, leprosy, syphilis. Chronic means you will blame all these. Fungus, rhinosporidiosis like this one here. So that can cause chronic dacryocystitis. Here what will be there? There will be no infection, they are saying. Mild inflammation, then mucocele is there. Then chronic suppurative dacryocystitis, then chronic fibrotic sac. It has become fibrotic. Chronic dacryocystitic complications they have mentioned here. Then finally coming to the treatment. Conservative treatment, you probe and lacrimal syringing, balloon catheter dilation, balloon dacryocystoplasty, yes. DCR, dacryocystorhinostomy, dacryocystectomy, DCR, conjunctivodacryocystorhinostomy. Learn all these things as from the detailed video. You can look at this. This is Jones test to check if there's obstruction. So we are done with lacrimal apparatus. Next is what? Orbit. So orbital infections, you have preseptal, this is, and then you have orbital cellulitis. Orbital cellulitis is actually an emergency, isn't it? That's why you should know how to differentiate preseptal cellulitis and orbital. Let us look at this. Wait. Preseptal, what is there here? Proptosis is absent. Ocular movements are normal. Conjunctiva is not conjunctiva. Visual acuity is fine. So remember, ocular movements are normal. Now coming to orbital cellulitis, here these people will have severe pain. When they move the eyeball, they have severe pain. When they move, they have more severe pain. In preseptal, they don't have that much pain when they move. Okay. Conjunctiva is affected here. Proptosis is there. Here there was no proptosis, no conjunctiva affected. What else? So same thing they are telling here. There is painful orbital swelling, but when they are moving, the eye movements are possible. And here what are they giving? Systemic antibiotics like co-amoxiclav, all that, flucloxacin, okay, ceftriaxone. Then coming to orbital cellulitis, here they are giving oxacillin, ampicillin, cefotaxime, all these. Surgical intervention. In orbit, the other important question is thyroid eye disease. So remember, in thyroid eye disease, thyroid is not the cause. It is the antibody which is attacking both thyroid and the eye. So remember, thyroid is also a victim in this case. So this antibody can make this thyroid to produce excess hormones or less hormones, or it could be a fine thyroid. So it could be hyperthyroidism, hypothyroidism, or euthyroidism. But this antibody can do any manifestation in thyroid, but is also affecting the eye. So this will lead to thyroid eye disease. In thyroid eye disease, what and all will you have? You will have lid retraction, lid lag and proptosis. Remember this image, lid is retracted, lid lag and proptosis. And this is also called as the endocrine exophthalmo. So many terminologies are there. So what are the risk factors? Female, middle age, who smokes, like that you can remember. Autoimmune thyroid disease they will have. So basically what is affected here? The orbital fibroblasts are affected. Then the extraocular muscles are affected. Here there will be adipogenesis, fibroblast proliferation, glycosaminoglycan synthesis, right? All these things you have to write in the exam, guys. So there will be edema, infiltration. So this eye will start getting popped out kind of a thing, proptosis. So lid signs you have seen, there are so many names here. So staring, frightened appearance, lid lag, edematous swelling, eversion of the upper lid, infrequent blinking, he's staring. So everything has a name here. Dalrymple, Von Graaff, Enroth, Gifford, Stellwag, all these signs you should know. Chemosis of conjunctiva, these include deep infection and chemosis conjunctival signs. Pupillary signs, less importance. Then you have Mobius sign. The convergence weakness is there. Exophthalmos, unilateral proptosis is not uncommon. Clinical features, continued optic neuropathy. So now they started, because of all the build-up in the orbit, looks like even the nerve is getting compressed. Papilloedema, optic atrophy. Graves ophthalmology, no specs classification, no signs and symptoms, only signs, no symptoms. Soft tissue involvement with signs and symptoms, proptosis. Extraocular muscle involvement is E, C is corneal involvement, S is sight loss. So no specs. Remember, P is proptosis, E is extraocular muscle involvement, C is corneal involvement, S is sight loss. So you can remember some 6 things there. Clinical course, it is self-limiting, but there is active phase and inactive phase. Clinical diagnosis is not difficult if it is an advanced case. Yes, we can see the staring. Investigations, what will you do? You will check for antibodies against what and all? Against the TSH receptors, against thyroid peroxidase, and against thyroglobulins. So many antibodies you will have which are against the thyroid, right? There could be thyroid stimulating antibodies. There could be anti-thyroid antibodies, right? So it could be either ways, like I told you, it could be hyperthyroidism or hypothyroidism. So you will do ultrasonography, then you will check the computerized tomographic scanning of the optic nerve, you will check MRI. This is what? What is this called as? Is it any uptake? Some uptake of radioactive substance by chance? Management, guys, you will have to do what? Clinical periodic workup, non-surgical, surgical, let's see. Clinical periodic workup, you keep checking how the symptoms are progressing, looks like. Least charting to decide the intervention. Ask them to stop smoking. Reducing periorbital edema. Okay. Surgical management, guys, what will they do? Improve function, to treat exposure keratitis. So they'll have to fix that lid, isn't it? What do you think? Because it's so retracted. Things are just going above your head, right? Yeah. Surgical management, you have 2-wall decompression, 3-wall decompression, 4-wall decompression. Remember, you have to decompress because it is compressed. You decompress 2-wall, 3-wall, 4-wall. That's important, guys. Don't forget. Then inferior rectus recession is the most common surgery they are saying. Then you have botulinum toxin. So all these are there for thyroid eye disease. Okay. Guys, we are moving on to ocular pharmacology. So in pharmacology, what and all are important questions? Look at this. Cycloplegic, mydriatics, and ophthalmology, right? So let us look at cycloplegics. So you have to remember these are cyclopentolate, home atropine, atropine. Cyclopentolate, home atropine, atropine. So if they ask you atropine sulfate also, you'll write same answer. So they are mydriatics also, okay? They are cycloplegics come mydriatics. What do these do? So you can see here in iridocyclitis, etc. Why are they giving them? So they're giving them so that they will relieve the spasm. Okay, they will relieve the spasm of the, see here, relieving spasm of the iris sphincter and ciliary muscle. So they are relieving the spasm. So they'll comfort and rest the eye. Prevents the formation of synechiae. Then reduce exudation. prevent synechiae, increase blood supply to anterior uvea. So all these are the way it's helping. So it looks like very good. They're just giving it for pain relief kind of thing, isn't it? So that is the treatment for iridocyclitis. For zoster keratitis, also they are giving. For scleritis, they are giving. Chemical burns, they are giving. Post-operative for cataract, they are giving. Then, if you want to do cycloplegic retinoscopy, then you will use this, right? If you want cycloplegia, remember these cause even mydriasis. In examination of heterophoria, they are talking about it for latent strabismus. So remember these dilate pupil. You actually want to achieve cycloplegia, but you are dilating pupil, so you have to give along with it these dark goggles so that they don't have photophobia. So cycloplegic, atropine, sulfate, both over. Remember atropine is 1%. Now let us move on to the next question. Steroids in ophthalmology. So corticosteroids, steroids in ophthalmology, immunosuppressive, anti-inflammatory. So these are the two things. Steroids are immunosuppressive also. These are anti-inflammatory drugs and steroids are immunosuppressive also. You're giving it for reducing inflammation, looks like. So what is this? Classification of steroids, preparation, mode of administration. So you have to talk about these. Loteprednol, you should remember, beta-methoxazone, dexamethasone, hydrocortisone, cortisone acetate. So you would use it in uveitis, scleritis, allergic conjunctivitis. Remember in vernal keratoconjunctivitis, you have studied this, right? So like tenular also is kind of allergic, so they are giving it in allergic conjunctivitis. Allergic keratitis also they are giving. Cystoid macular edema they are giving. Uveitis, scleritis they are giving. Uveitis, scleritis, don't forget. I'm sure you will write allergic conjunctivitis and allergic keratitis because it is allergic reaction. You are giving steroids. You'll remember that very well. Remember for uveitis and scleritis also. Systemic also available. Prednisolone, dexamethasone, beta-methasone. So these are all the indications in posterior. What is this? Systemic preparations are indicated in posterior uveitis. This word should come here, isn't it? And then sympathetic ophthalmia. All these conditions you can write. Corneal grafts rejections, they want to give steroids so that you can reduce the immune action, right? We have also seen the side effects, glaucoma, cataract. It can cause glaucoma and cataract. Strange, right? Newer anti-glaucoma drugs, let us look at, guys. Newer anti-glaucoma drugs are here. So you should just remember ABC. A is for what? This F2 alpha, prostaglandins, okay? Prostaglandins, you remember like that if you want. Newer they are asking, right? So you can write prostaglandins, beta blockers and carbonic anhydrase inhibitors. So instead of prostaglandins, I'm just making it an A here because F2 alpha. Prostaglandin, F2 alpha it is. So you remember, instead of P, so it's actually P, B and C. This P I'll make it like an A, A, B, C. So you can remember these are the newer anti-glaucoma drugs. So you should remember prostaglandin, what and all you'll write, latanoprost, bimatoprost. What will you write for beta blocker? Timolol, levobunolol, betoxolol. What will you write for carbonic anhydrase inhibitors? Brimzolamide, dorzolamide and acetazolamide. So you have to write this much, that's it. Who is increasing outflow? Prostaglandins are increasing outflow. Who is reducing the production? Production is being reduced by all these inhibitors, blockers. These are reducing the production. Okay, that's all. These are the newer anti-glaucoma drugs. Apart from that, you can write mannitol. Mannitol you should not forget, right? So where is mannitol here? Mannitol. So they are using it to reduce in acute congestive glaucoma. They are giving it. So next question, timolol maleate. This is a beta blocker, isn't it? Mode of action. What is the mode of action? What are the side effects? We already saw this anyways. Where is it? Anti-glaucoma drugs. So here we have seen that timolol maleate, where does it come? Here. Timolol maleate comes here. It is a beta blocker. It reduces the secretion. The other options will be levobunolol and betoxolol. Remember, these are actually beta blockers, so they can affect the they can affect the heart, right? They can cause dry eyes. They can cause NLD block. So this betoxolol is better because it is beta 1 blocker. It is. So for asthma people, COPD and all you can give, looks like. But when it comes to timolol, This is a beta blocker, beta 1 and beta 2. So it will have effect on COPD patients, heart, etc. See here, beta 2 was supposed to dilate, right? Now they are blocking it. So what will happen? It will constrict. So COPD people will have a lot of problems. So they don't want to give this beta 2 blocker like timolol. So what they want to give? They don't want to give this. So they want to give betoxolol. So remember, timolol, levobunolol, all are same category. Levobunolol. Can you say levo?
Levo.
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 Bunolol.
Bunolol.
Yeah. Hello people, let us continue with the important questions. Now cherry red spot. Now where and all do you see cherry red spot? Let's look at that. Cherry red spot. It is seen in the center of the macula due to vascular choroid shining through the thin retina. So retina is thin, so from inside that the choroid, the red color is shining. Vascular choroid is shining through the thin retina in the foveal region. In the center of the macula. In the center of macula, what is there? Fovea. In the foveal region, what is there? The retina. And then below that, you have choroid. Now, retina has become very thin. So, behind that, whatever choroid is there, vascular choroid, so red color, it is looking nice. Okay, you understood, right? So, surrounding will be pale retina. That is also there. It's not just that this is red. Surrounding, it should be pale retina. Both you're able to see, right? So, this is cherry red spot. Okay. Where do you see it? Okay, we see it in central retinal artery occlusion. Commotio retinae, that is Berlin's edema. Tay-Sachs disease, Niemann-Pick's disease, Gaucher disease. So you have to write all these in the exam. If they ask cherry red spot, these 5 words should come out. What are the 5 terms that should come out? Central retinal artery occlusion, CRAO. Commotio retinae, Berlin's edema. Commotio retinae, where do you see, guys? This is following blow to the eye, you will see in the retina, commotio retinae, Berlin's edema. So there also you'll see cherry red spot. Punch that guy, okay, in the eye. Okay, don't punch. Tay-Sachs disease. Tay-Sachs disease is what? This one, there is destruction of the nerve cells. So obviously, guys, so you can understand now, right? So retina. So cherry red spot. Retina became thinned out. Niemann-Pick's disease. So fatty substances or lipid accumulation in brain, you can say. So basically lipid storage disorder. Then Gaucher's disease. This is also same thing, lipid is accumulating everywhere, looks like, okay? So in all these cases, you will see cherry red spot. Can you list the causes? Okay, very good. So now let us move on to the next important question. Vitamin A deficiencies that will cause what? XeroOphthalmia. In this, basically you should know, this is ocular manifestations of vitamin A deficiencies. So here you should mainly know the classification, okay, WHO classification, XN. See, conjunctivitis, first conjunctivitis, so XN, night blindness, conjunctival xerosis starts with night blindness. Imagine, starts with night blindness. After that, it looks like even worse. Conjunctival xerosis, bitote spots, they will ask in the exam. Bulbar retici on the bulbar conjunctiva, raised, foamy, silvery, white, keratinized epithelium, bilateral and temporal side. Remember, it is bilateral condition. Then you have corneal xerosis, X2. X2 is what? Corneal xerosis. X3A, 3B is corneal ulceration, keratomalacia, it is melting off. X3 is corneal excess. What am I saying? XS is corneal scar. After X3 comes what? XS. There is no 4. Okay. Then you have XF, xerophthalmic fundus. So this classification you should know. What is keratomalacia? Necrosis, melting. You can remember there will be delayed dark adaptation, night blindness. There are a lot of other causes. So treat. How will you treat? Above 1 year person means you will give 2 lakh international unit. Above 1 year. Below 1 year you will give 1 lakh international unit. Okay. Then a lot of prophylaxis with measles vaccine and all they will give. That and all you know, right? Natural sources of vitamin A. All this you have to write in the exam. Now let us move on to the next important questions. Pitote spots we finished. Legal, economic, social blindness. Define. So you have to define so many types of blindness. So you know this anyways, right? Definition of blindness. There are so many definitions. WHO definition, NPCBVI definition. Look at this. This will summarize everything. Basically, from here starts the blindness. Below that, whatever you're seeing is visual impairment. Anyways, economic blindness is severe visual impairment is economic blindness, less than 6/60. Less than 3/60 is social blindness, WHO, NPCBV. Less than 1/60 is legal blindness or manifest, right? That's what is legal blindness or manifest. Total means there's no perception of light, okay? Smart people are asking causes also. Causes, what will you write, guys? Causes, same thing. You write cataract, childhood blindness, xerophthalmia, trachoma, refractive errors, glaucoma, corneal blindness, diabetic retinopathy as main causes you can write. So top infective cause will be trachoma and onchocerciasis, and non-infective will be cataract, glaucoma, etc. Next important question, community ophthalmology, Vision 2020. So in Vision 2020, do you remember what you have studied in Vision 20? Yeah, that's why we have to take a recap. So right to sight, remember, what is it? By year 2020 vision, right? Reduce the global burden of blindness, eliminate avoidable blindness. 5-year plans are there. Then these are the 5 things that they included in the world. But India removed onchocerciasis and added what and all? India added glaucoma, diabetic retinopathy, and corneal blindness. Remember, childhood blindness is also there, XeroOphthalmia, etc. So there is some structure for Vision 2020, guys. Primary, secondary, tertiary. Primary, you have some vision centers. Secondary, you have service centers. Tertiary, you have training centers and centers for excellence. You should know these. 20,000 vision centers, 2,000 service centers, 200 training centers, and 20 centers of excellence. 20, 200, 2,000, 20,000. Remember. Then what else you have here? Vision centers, 20,000. You know that, right? That's it. Then you have National Program of National Program for Control of Blindness and Visual Impairment. This is India one. This was there much before Vision 2020. So when Vision 2020 was given, our country adopted Vision 2020 into our existing National Program for Control of Blindness and Visual Impairment. Last question, childhood blindness. Childhood blindness, we have already seen. What have you seen? What is the prevalence? We have seen 1 in 1,000 child like that. So what are the causes? You should write this. This is what they're looking for. Vitamin A deficiency, measles, conjunctivitis. Just go anatomically, you will get a lot of things. Conjunctivitis, ophthalmia neonatorum is conjunctivitis again. Cataract, congenital cataract. You can name all those cataracts, zonular, etc. Then retinopathy of prematurity because of the oxygen, right? And in injuries, yes, these children get injured. Childhood glaucoma. Then the refractive errors you should write. It's the commonest cause of visual impairment. And let's put it here. What do you say? Commonest cause of visual impairment. Okay. Then childhood blindness. So visual impairment is not actually blindness, right? So should we put it here or here? What do you think? Anyways, remember refractive error is the commonest cause of visual impairment. Childhood blindness aim is to eliminate avoidable causes of childhood blindness by 2020. Same Vision 2020. Here they're talking about childhood blindness. Strategies. How will you do all this? Primary eye care. Teachers will be able to tell whether this child is able to see properly. Then detect the eye disorders, avoid squint, amblyopia, XeroOphthalmia, give them vitamin A prophylaxis, trachoma, hygiene, safe regimen, curable. You should check for cataract and ROP, corneal opacity. Each of this you have to elaborate, guys. ROP and all, retinopathy of prematurity and all you will write, right? Pediatric ophthalmology, establish these units. Then activities, eliminate preventable blindness. Measles immunization. Management of surgically avoidable causes. So, what am I saying? Yeah, surgically avoidable means cataract and all. Yeah, okay. So guys, in this video, we looked at the important questions of ophthalmology part 2. Hope you will have a safe exam. Bye-bye.